Well, BRCA1 and BRCA2 testing has been around for a long time, since 1996. Myriad Genetic Laboratories was the first lab and the only lab for quite a while to offer this genetic testing because they held a patent for the genes and the gene testing. Nowadays, there are lots of different laboratories that can offer it because that patent has gone away. Myriad Genetic Laboratories made some changes to their testing along the way, and one of the important developments that they made was called BART testing. So at first they were sequencing the genes and looking for common changes within the BRCA1 and 2. With additional testing and research, they recognized that there were changes called deletions and duplications, or rearrangements in the DNA, that weren't being detected by the earlier test. So they added a second part of the test called BART, which is the rearrangement testing. Some women who had genetic testing early on with BRCA1 and 2 may have had a negative test, and there's a chance that there could be a rearrangement mutation still there that was undetected. So when we have a woman come into clinic these days, we'll look at that, and if she needs to update her testing with the additional aspect known as BART, we would offer that. If a woman is starting fresh with testing these days and she's having BRCA1 and 2, it's typically going to include the BART or the rearrangement testing, regardless of the laboratory. But of course, the patient would certainly want to make sure of that. So, having completely updated testing and a negative BRCA1 and 2 test, there are a lot of factors that a patient could consider as to why they had a negative test result. One might be they simply just don't have a mutation in their family, and so in that case, obviously a negative result would be quite reassuring. However, there's always a chance that with testing, and we estimate perhaps 5% of mutations are not detected by current testing. We just don't have a better test to figure that out. So it's possible that there is a mutation, but that it simply couldn't be detected by current testing standards today. That's another possibility. Another possibility is that we're testing the wrong person in the family. So if a woman comes in and she has never had cancer before in her life, but she lost her mother and her sister and maybe an aunt, all to related cancers, and she had testing and it was negative, we can't really say for sure whether her testing was negative because she simply didn't inherit the mutation, which would be reassuring because she'd be at background risk, or maybe the test isn't picking up the mutation that could be there in the family. So the best way to figure that out is always by testing someone in the family who has had cancer, the most likely person to carry a mutation, so the youngest person perhaps, or the rarest cancer, and then use the results of that to help determine whether unaffected relatives need testing or not. So the context of the BRCA1 and 2 test that was done is really important. Did we really test the right person in this case, if we could, or not? Because a negative result can be more or less reassuring then, depending on that context. Another possibility would be that perhaps there's a whole nother gene that we haven't considered yet. Early on with BRCA1 and 2 testing, really these were the only genes that we could test for clinically for inherited breast cancer predisposition. But nowadays we're running what we call panel tests, so big groups of genes. There's one that I look at frequently that includes up to 10 other genes that are associated with inherited breast cancer beyond BRCA1 and 2. So if a woman has had negative BRCA1 and 2 testing, it's important to consider whether there could be another related gene. And some of these genes are sort of what I call plain vanilla breast cancer in the family, where there really aren't any other clues which gene to look at. But some of these genes have other clues. For example, there's a gene called PTEN that we often will see thyroid cancer, renal carcinoma, or even uterine fibroids or uterine cancer associated with that gene. Or there's another gene called PALB2 that is more associated with breast and pancreatic cancer. So I, as a genetic counselor, would look at the family history very carefully and identify, is there a possibility that maybe we should look at some other genes? And we can do what we call update testing now, where we add-on genetic analysis for other genes that were not tested in the original BRCA1 and 2. So there's a lot of options. I definitely recommend working with a genetic counselor or someone very well trained in genetics to make the decision about doing any other genetic testing. But a lot of things to consider there.
Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
About personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.